afternoon and welcome to AHCC Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and health assessment data collection issues that matter most to home health and hospice. AHCC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for AHCC, and I'm happy to be hosting today's call. And this afternoon, we're talking about creating a compliant plan of care and sharing some news about a new guide created by the AHCC Documentation Integrity Committee. And now I'd like to introduce our industry guests for this episode. Today, we have AHCC Advisory Board Chair, Sherri Parson, and AHCC Advisory Board Member, Griffin with us. Thanks so much for joining us today, ladies.
Thanks for having us.
All right, we are going to kick things off with an audience poll. Since we are talking about creating a compliant plan of care, we'd like to know, for those of you who are listening live, what is your relationship to the plan of care? Are you involved in creating it, reviewing it, carrying it out, not really involved at all, or something else? And if you do choose something else, please share what that is in the chat or question pane. All right, I see folks are still voting, so I'm going to give it a few more seconds so we can gather that. And we will, once everybody's finished voting, I'll close the poll, and then we will take a look at the results a little bit later in the call. Okay, it looks like voting is slowing down, so I'm going to go ahead and close this out, and we'll discuss the results a little later on. All right. Before we get the discussion started today, listeners, if you have any questions for our panelists, please go ahead and ask them in the chat pane, and we'll try to get to as many of those questions as we can. And Sherri and Janan, I'm going to turn things over to you, but just let me know as we need to move through the slides when to advance, and I'll take care of that for you.
All right, thank you, Jan. And if you want to go ahead and switch to that slide, thank you very much. So I want to thank everybody for joining us today. We wanted to spend this AHCC Talk highlighting the new home health guide to crafting a compliant plan of care that has finally reached publication. We're very excited about that. This is a document that was created by the AHCC Documentation Integrity Committee over a significant period of time, and it has morphed into this robust publication. Janan and I wanted to take this opportunity today not only to highlight this document, but to also discuss some other tips, considerations when developing a home health plan of care. Now, one of the overarching themes you'll see again and again is our first statement here, that the plan of care needs to be individualized to each patient. We will bring this up over and over, since this is very important in the development of a patient plan of care. So with that, please keep in mind when using this tool that it's a template. It's not really to be copied word for word, but rather adapted to your specific patient. And when leveraged correctly, a well thought out plan of care can optimize patient outcomes. And of course, not only does that result in better performance scores, but most often positive surveys coming back into your organization as well. Next slide, please, Jan. First, I think it's important to mention that there are many plan of care elements and the requirements per the conditions of participation. And though this tool is robust, it only really focuses on one aspect of this list, and that's the interventions and goals that I have circled here. The other elements that the condition of participation mandates are things like all pertinent diagnoses, the patient's mental, social, cognitive status. And of course, as you think of your EMRs and what information is pulled out into your plan of care, you probably can see all of those elements that are populating within your EMR when you get to the plan of care. The types of services, supplies, equipment requirements, the frequency, duration of visits to be made, prognosis, rehab potential, functional limitations, activities permitted, nutritional requirements, all the medications and treatments, safety measures to protect against injury, a description of the patient's risk for the emergency department or readmission to the hospital, patient and caregiver education. We also have those interventions and goals. That is, again, what the tool really focuses in on and hones in on. Information related to any advanced directives the patient may have, and additional items that the home health agency or the physician may want to include on a plan of care. Next slide, please, Jan. So additional items to keep in mind, though not all diagnoses have to have interventions and goals. When we're looking at that primary diagnosis, that focus of care, we want to make sure that we have interventions and goals related to that. And keep in mind that when we're talking about a focus of care, a primary diagnosis, that sometimes we can have a couple that meet that criteria or that definition, but this is really why we opened that patient to home health. What is it that home health is doing for that patient? Patient has to have home health following them. That'll probably guide you to what that focus of care is if it's unclear. We want to make sure, again, that we're including a description of the patient's risk for emergency visits, hospitalization. Of course, we've got some tools within our OASIS that helps us kind of come up with some interventions and goals related to that. Of course, the guide will also provide some of that. If you're kind of not sure what to include there, we'll have some things to stimulate what it is that you assign in there. Patient-specific goal. The plan should include at least one patient-stated goal. So maybe your patient wants to be able to make it down to the mailbox to gather their mail, for example. We want to include something that is specifically something that that patient is wanting to accomplish in that plan of care. Again, we get buy-in from the patient with that. And of course, if we can achieve that as far as an outcome, we'll get really positive responses, especially maybe with surveys coming back to us because we were able to do that for that patient. We want to include short and long-term goals. So this is important. All of our goals should not have the same date. Now, I'm sure Janan has seen this too, but I have seen where every single goal is for the, the entire duration of that certification period or whenever that patient is going to be open. And we want to make sure that we have variation there, that we have some short-term goals, long-term goals. When I think of our CHF patients, our COPD, end-stage patients, we're probably going to make sure that after that first visit that they understand, either with a stoplight tool or we've got a list of those things that are going to warrant a call to the nurse immediately, ER if necessary, the physician. We want to make sure that they're equipped to know when they're in trouble. So that would not be something that we want to accomplish by the end of the certification period, but we would want to make sure that we had taken care of that probably the first visit, at the end of the first visit. Intervention, yes, go ahead.
Hey, I would say also that the therapists are pretty good at short and long-term goals. It seems to be nursing that seems to struggle with those short and long-term goals. I don't know if it's because we have them during the whole entire episode and why that is, but I think nursing does need to work on that. Even medications, you don't wait until the end of the 9 weeks to teach all the medications. So
right, exactly, and vice versa. You don't do them all on the first visit either.
Correct.
Yes, but that's a great point, Janan, and I agree totally. I think that therapy, as a general rule, does much better on having different goals for different weeks. And yeah, nursing, I do see often just they're all the same, which we don't want to have. So good point. I agree wholeheartedly with that. Interventions, all goals should at least have one intervention, and that's because the interventions are really how we get to the goals, right? So those are like the building blocks to get to the goals. So you're going to have something that you're going to be doing as a home care agency to get to that goal. There could be actually multiples to get to one goal. So again, just making sure that you do have interventions that match up with those goals. PRN visit details. Again, that's got to be specific to the patient. So, and it has to be specific in general. I have seen some plan of cares where the PRN visits for any problem developing with the patient, which is not going to be specific enough for the criteria to use those PRN visits. So we want to make sure that we've got some criteria there. Maybe you have a catheter patient, PRN visits for, catheter issues, something like that. And then verbal order details need to be part of that plan of care if we have established our plan of care based on a verbal order. Next slide, please, Jan. And so when we create a plan of care, again, we want to be specific to that patient. And I think one of the things that I'm seeing with us using these EMRs is that basically if you've got a patient that has a CHF, let's say patient A, and patient B has CHF, that a lot of times their plan of cares can look exactly the same if we just copy and paste what is in that EMR. And we want to make sure, again, that we're individualizing that according to our patients' prior level of function, their functional status, their knowledge deficits, barriers that they may have in their living situation, maybe barriers that they have, maybe they're got dexterity issues, they have some low vision, but we want to make sure that, again, when we're looking at this plan of care, we can tell that we're talking about patient A, and that patient A and patient B, just because they have the same diagnoses, do not look identical. Next slide, please. So things to keep in mind, when we have certain things present with patients, it would be a good idea to have interventions or goals around that. You've got somebody that's a high fall risk. They've got a history of falls. They have very positive MAC. You are going to want to include some interventions and goals to address those fall risks. Depression, maybe they have some active symptoms with depression, new medications, they're positive for the screening. We're going to want to include some interventions and goals for that depression. Pain, if they've got significant pain, we're going to want to include interventions and goals for mitigation and monitoring that pain. And same with pressure ulcers. If we have somebody that's at high risk for that, we're going to probably want to include an intervention or a goal related to that. Next slide, please, Jan. And with that, there are certain diagnoses that I consider big hitters. And so even if they're not your focus of care, they're down on the list a bit. You've got a patient with, CHF, diabetes, all of these things on this list here, wounds, anticoagulation therapy. These significant diagnoses or therapies are things that we're going to want to capture, if nothing else, that for safety reasons with our patients. So this could serve as kind of a good guide as to when we may want to add some interventions and goals. Next slide, please, Jan. But I'm going to look like I'm contradicting myself here. So, right, I've given you all of these things for interventions and goals, but we still want to keep the plan of care simple. We want to limit the goals. Again, we want to be specific to that patient, but we want to make sure that we're actually able to accomplish all of that within the time frame that we are in that home. We also want to make sure that we're making changes with the plan of care throughout the episode. So if something changes with our patient, of course, but I'm thinking of even completing them. I don't know how many times that I have seen, individuals get training or teaching on the same medication every single visit through an entire, certification period, or they, have gotten the same training on the CHF when there's multiple aspects of CHF. Maybe it's the fluid precaution or fluid restrictions and weight parameters, but what I'm seeing is the same thing all the way through. And again, as we complete a goal, we're going to want to mark that completed in our EMRs. And, again, we want to focus on different aspects of that, because again, there's probably a lot of skill that is needed with some of these patients. We've got higher acuity these days with our patients, so we want to reflect that in our documentation as well in our plan of care. And then maintaining contact with that physician. We want to have that collaboration. And then QA staff. You know, our QA staff come in after we've already closed out a patient, and finding out that we taught the same med all the way through, or we missed some of these goals and interventions is not very helpful. So finding a way to, you know, actually kind of catch some of that while that episode is still open, in case we have missed something or there's something that we need to tweak. If we can find out, you know, develop a process with our QA staff in order to do that, that would go a long way, I think, in perfecting what it is that we're doing. Next slide, please, Jan. All right, so some identified plan of care risks. You know, I think John and I said we could spend the whole time that we have here just kind of talking about this and things that we've seen over the years. So, you know, John, feel free to kind of jump in. You know, improper coding, you know, I have seen multiple times when, you know, maybe somebody just click the wrong button, and it's a diagnosis either the patient totally doesn't even have, it's a body part that they don't even have, you know, cancer in, or I have seen where we have, you know, coded male diagnoses on females or vice versa. Janan, anything that comes to mind?
Laterality, they had it left knee done, but we put a right knee, things like that. I see a lot of.
Yes, absolutely. And so some of these things aren't going to get kicked out as wrong codes. I think usually if you do a female code on a male, you might get that kicked out right away. But, you know, something to Janan's point, you know, the wrong laterality, you know, that won't necessarily, because it's a valid code, it won't necessarily kick out, right? So improper sequencing of coding. I saw this a lot when we first went to ICD-10 or PDGM. I think everybody was thinking that complex nursing would, because of the name, it just garnered more points, and I'd see things up at the top there that shouldn't have been up at the top, you know, as a focus of care. You know, Janan, anything you see with that sequencing?
I mean, I still see, I would say more so inexperienced coders, like bundled codes, like the CHF, the hypertension, the CKD, diabetes, you know, not sequencing that correctly or not putting them kind of together in a bundle. I don't know any other way to say it, but that group of codes together, it may be spread apart, right? The I-13 code, and then, you know, 4 more down, they put a CHF code, and again, more for the inexperienced coders, which is really leans to why people need to be certified and understand the coding rules. Rather than just think, oh, well, you know, that EMR gives them to us, or my intake has AI and it gives them to us. That may not necessarily be the correct way, or the physician codes everything. We all know that that's not correct.
Right, exactly. But I have seen, to your point, new coders and like, well, the doctor wrote that down. Well, it isn't correct. You know, you go by the description, not that code that they put down that they just ran through whatever, you know, AI or Google that they used. So yeah, good point. Very good point. You know, frequencies inconsistent with the patient condition. I have seen some of the sickest people have 1 week, you know, 1 week visits, you know, and it's like you're only going once a week, and they've got all of the, they're very severe. And of course, that's inconsistent with what we should be doing for that patient. Any horror stories you can think of, Janan?
I see it a lot with, okay, maybe in the middle of a plan of care, but really the plan of care is not static. It goes on all the time, right? The whole entire time we're seeing the patient. But I see it a lot where the nurse did a great job identifying a problem, called the doctor, and they just kept going the same frequency. They didn't increase the visits. And so to an auditor, that's going to look like, well, it wasn't that urgent. You know, it wasn't that big of a deal, because you didn't increase your visits. And I know everybody's under a lot of pressure, you know, with margins and all that, but we still have to take care of the patient. So we have to figure out a way to do it effectively. And in turn, you know, maybe we don't do that visit, those 3 visits, like you said, that we're teaching how to elevate your legs for edema, or the same medicine every time. So we are thoughtful in our plan of care and how we're carrying it out.
Right. Well, I think one I've seen too is where they've got one visit a week, but then they skip, for some reason, maybe the patient has a doctor's appointment and then they don't go for 2 weeks. And then, again, if they're well enough to be alone for 2 weeks, then are we really needed in there? And it really doesn't support that. So we probably need to make those visits up and not just skip an entire week, even if it is once a week, twice a week. We want to probably make sure that we're trying to make those visits up. I think that happens quite a bit. So, yeah. Generalized PRN orders, I kind of, hit on that. I have seen all kinds of things written there to encompass, or, there is specific criteria and then the patient fell, maybe your PRN specifics are for a catheter and then, the patient fell and then they're trying to use that same PRN order instead of getting a new order. Janan, anything you see related to that?
I mean, I really tried to think that, again, not making it individualized. People try to lump PRN orders all together for a changing condition or for, 5 for a Foley catheter, or if the patient fell, or, and they try to just lump it all together.
Yes.
Yeah. So I see that a lot.
Yeah, I agree. Orders not followed. I think we could have lots of examples here, and I think people don't even necessarily understand. I have looked at documentation, for example, patient is compliant with their PRN, O2 at 4 liters, but the order is really for around the clock 2 liters, so we've documented that, we're thinking we're doing great documenting it, but it's not consistent with what was ordered for the patient. Any examples you can think of, Janan, that you've seen?
Wound care. I mean, it's always at the top. Wound care is like we maybe changed it and didn't write an order, or that we didn't do the steps, or we put the wrong steps, or we didn't have this medicine, or this dressing, so we tried to, use another one that we had in our bag. I see that a lot also.
Oh, yeah, I think that's a really good one. Medications listed are inconsistent with meds in the home or other parts of the clinical record. I know we got nailed on a survey recently. The nurse had, talked about how the patient had taken their Motrin for pain, but of course, what was not on our med list anywhere in the chart? Motrin. Being consistent again with what's ordered, what you're documenting. Anything you want to add to that, Janan?
I mean, that's one of the top 10 every time. If you look at, ACHC, CHAP, CMS, that medications not matching is always.
Yes. And, obviously that's where patients can be injured a lot of times, changing settings and, having, meds that aren't reconciled between one setting or, one provider and another provider. So yeah, for sure. Frequency and goals are not individualized or excessive in numbers. And so again, it's very convenient in some of these EMRs and check. And there's pages and pages and pages. And like I said, you can't possibly in however many weeks you're going to be there, get through all of those. Anything you want to add to that, Janan?
No, I think EMRs have done a little bit of a disservice trying to make everything so easy. It's almost like mindless, and so we're just going down checking a lot of things. We end up with a 15-page plan of care that nobody's ever going to do, and as you said, in the time frame that we're there.
Right, absolutely. And then you had some stuff that you just found out related to provider signature, so I'm going to let you talk a little bit about that.
Just a verification, because some entities have been allowing, some audit entities have been allowing wet signatures and dated and typed dates. But I was just on a call with Palmetto, and they said, like, no, if it's wet signature, it needs to be wet dates, and if it's not a stamped, but a electronic signature, then it needs to be electronic dates. And so it needs to be consistent with both, or you're at a risk of denial.
Yeah.
Even in RCD state.
Yeah. Well, I'm going to hand it over to you to get into some of the specifics that we can find in the guide. And Jan, if you want to turn to the next slide, please.
So again, exciting times when we have this, that the Documentation Integrity Committee did a great job on the interventions and goals and a compliant plan of care. Here's just an example. Again, as Sherri said earlier, these are just examples. You do need to make them patient specific with timeframes and all of that. So some examples of like aftercare of surgery, you know, what to expect after surgery, the provider orders, post-op precautions. You have some, you know, that have standard orders, those kind of things, infection control, if they have wound care, what kind of wound care, signs and symptoms to report, any medication, education, pain management, safety measures, trying to prevent blood clots, and when to notify somebody if they start having signs and symptoms of those, any ordered therapy, home exercise program, pneumonia preventative measures, because patients are not as mobile as they were before, and so that's important. I think we often forget about nutrition as in pressure ulcer prevention. And then be sure to instruct them that even though over-the-counter sound benign and it's not really a problem, but there may be some interaction they have with the medicine that they're currently taking. So before they start taking anything, they need to check with their physician or provider to make sure that they can take those supplements or herbal medicines or vitamins or anything like that. Next slide, please, Jan. So you'll see this in the guide, and it's kind of a decision tree type of thing. So some aftercare goal intervention pairing examples. The goal would be patient and caregiver will verbalize understanding of surgical aftercare precautions to follow and signs and symptoms to report within 1 week. And the intervention for that is skill nurse to educate patient and caregiver on what to expect after surgery and ordered precautions. And we're running a little short on time, so I'm going to just say that those kind of pair the interventions and goals. Again, just examples, but it is a good template that if you're looking for things. I know when I was in nursing school, I used to take those nursing care plan books that had and try to go down my nursing care plan books because they worded it sometimes better than I did. And this may word it better than even an EMR could do it. So don't, you know, go too overboard and try to say, again, hey, this book is great, let's do all these interventions and goals, because you're going to end up with a 15-page care plan anyway. So
yes, good point.
Jan. Just some examples of cardiac condition of intervention items. Document any education provided as well as verbalization of the understanding and ongoing demonstration of compliance throughout that episode. Be sure to include teaching on medications, whether new, changed, or other medications that patient may not understand. You should always be documenting what the patient doesn't understand and really teach those things first rather than going down the laundry list of medications. Include teaching on any disease-specific management techniques, you know, checking blood pressure or heart rate, or if they're having to do daily weights because they're CHF, and some sort of log that they can show to their provider when they go to the doctor, or can show to the home health agency when they come. You're going to include assessment of any type of cardiac system for normal or abnormal findings. And again, it'll vary depending on what's going on with the patient. Do they have AFib? Do they have CHF? Do they have just CAD, hypertension? And then include teaching on pathophysiology of the disease process, signs and symptoms to report, and appropriate management techniques such as medication, diet, exercise in the plan of care orders. And then a decision tree based on that. Again, just like the aftercare, is the intervention and goals that match. And again, will be specific to your patient, and be sure to include whatever's going on as your primary reason, and if there's anything pertinent, because it may not be the primary focus of care. Wound care may be, but they may also have new AFib, and you need to include signs and interventions and goals related to those. And then Jan, I think that's it.
Yes, yes. Thank you so much, Anan and
Sure.
Sherri. So much good stuff there. We're so excited to have this guide out there in the world. And I want to let everyone listening today know that we've included one section from that home health guide to crafting a compliant plan of care along with the handouts in GoToWebinar today. So you can see what a full section for one condition would look like. And if you are an AHC member, we've added a few more sections in the resources tools library. So you can pop over to the AHC website and check those out to see some additional details on several conditions. So thanks again, ladies. Let's take a quick look at our poll results. If I could get my mouse working here, it's a little sluggish today. Okay, here we go. So we asked you, what is your relationship to the plan of care? And the majority of folks on the call today are reviewing it. And then about a quarter of the folks who voted here also are creating it. So good to have those details about what you're doing with the plan of care. And we'll keep those in mind as we develop future tools and future topics. So thanks to everybody for voting on that. All right, and now it is time for our scenario spotlight. Oh my, pardon my sluggish mouse today. Okay, well, it looks like I can click through, but I think am I still showing the poll, ladies?
Yes, you're still showing the poll.
Okay, here, my mouse is, there we go. Okay, I think I'm back in order.
Yeah,
Thank
you're
you.
good.
Okay, great. Okay, scenario spotlight. In January, we had a spotlight where we looked at a patient, or a scenario where we looked at a patient who fell while standing on one foot, working on increasing their balance during PT. And the scenario asked you to determine the best scoring for J1800, any falls since start of care or resumption of care, and J1900, number of falls since start of care, resumption of care. And our answer to that January scenario is J1800 would be answered 1, yes, and J1900 would be C, major injury 1. And this is because of those new updated falls definitions that were released in early January and that were effective retroactive to January 1. And although these definitions were also mentioned in the fourth quarter OASIS Q&As, the errata with all the detail was released several months after those Q&As and after January 1. The updated fall definition continues to state that an intercepted fall occurs while therapy is intentionally challenging a patient's balance, assuming there's no injury. It's not considered a fall. However, the guidance has been updated to reflect that if a patient has a major injury, such as a fracture from an intercepted fall, while therapy is intentionally challenging a patient's balance, it is considered a fall with major injury. And we've included some links for the details on those changes. And we did talk about these falls changes and the falls measure in our last AHC talk. So if you didn't get to join us for that call, the recording is on the AHC website, or you can find that to listen to on your favorite podcast episode. And we have a new scenario for February, and the February scenario is a plan of care scenario. So in this situation, an 84-year-old male was hospitalized for COPD exacerbation, and the patient is oxygen dependent and has nebulizer treatments every 4 to 6 hours. The patient's other comorbidities include hypertension that is well managed with medication, type 2 diabetes with a sliding scale of Humalog and Lantus. Patient also has hypothyroidism, hyperlipidemia, and anxiety. And the RN case manager has admitted the patient to home health and is now preparing the plan of care for this patient. And our question is, what conditions should be considered when establishing goals and interventions on the plan of care based on industry best practices? So give that a think, and on our March call, we will discuss that and share an answer for that scenario. And next up is our product spotlight. And this month's episode of AHC Talk is brought to you by the Home Care Leadership Summit happening May 19th through the 21st in Orlando, Florida. You can save up to $100 when you register before March 11, and don't miss your chance to join industry leaders, gain actionable insights, and connect with peers, all at a discounted rate. Secure your spot today and make this year's summit your most impactful one yet. To learn more or reserve your spot at the Home Care Leadership Summit, you can visit the link in your handouts, and that's decisionhealth.com/HCLS2026. And if you're listening to a podcast version of this call, you'll find the handouts, including the link to the including this link on the AHC website under Resources, Free Webinars. And now it's time for What's New with AHC, where we share updates from the Association of Home Care Coding and Compliance. If you are an AHC member, we have a members networking call coming up on March 31st. Check the February AHC e-zine, which should hit your inbox today, for the link to register. And on this call, we'll be breaking into small groups to work on scenarios with fellow AHC members and members of the AHC Education Committee. And I also want to share a link to the Home Health Guide to Crafting a Compliant Plan of Care. As we mentioned earlier, this guide was developed by the AHC Documentation Integrity Committee, and we're so excited to share it with all of you. You can download a section from the guide and see the full table of contents on the Decision Health store. Just search Plan of Care. We hope you enjoyed this episode of AHC Talk. Thanks again, Sherri and Janan, for all this great information. And thanks to all of you for tuning in. We hope you'll join us again for our March call on the 16th. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can find AHC Talk on your favorite podcast app. Or you can also listen to the recording and access the handouts on the AHC website at ahc.decisionhealth.com. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening, and thanks again, Sherri and Janan, and we'll see you all next month. Take care.